Hello friends, welcome to Cortex YouTube channel. In this video, I'm going to discuss about a case. So, case is like this: a young female with scleroderma presents with progressive dyspnea on exertion. On examination, there will be loud P2 and holosystolic murmur that exhibit respirophasic variations, heard best at the lower left sternal border. A routine ECG is obtained and is given below. So, what is the most likely cause of the patient's symptom and what ECG findings support this diagnosis? So, looking at the history, here a young female with scleroderma presenting with progressive dyspnea and exertion. In the background of autoimmune disease like scleroderma and progressive dyspnea in a young female suggestive of pulmonary artery hypertension, development of pulmonary artery hypertension. And our examination also supports that, our history diagnosis. So that is loud P2 and holosystolic murmur at around pulmonary area. That means there is a pressure gradient established between right ventricular and pulmonary artery. So we just have to look at the ECG and confirm our diagnosis or support our diagnosis. So let us look at the ECG. So this is lead 1, 2 and this is 3. Okay, so first thing we have to comment about, assuming that it is taken in the proper or normal standardization, let us look at the rhythm first. So any ECG you have to comment rhythm first. So for that you have to see lead 2. So lead 2 you have to see P wave, QRS, P wave, QRS, P wave, QRS. So every P wave is followed by QRS, every P wave is followed by QRS, and RR interval looks normal or regular. So RR interval is equal to RR interval. Every P wave is followed by QRS, and all P waves are looking same. So this is in sinus rhythm. Rhythm is sinus rhythm. After knowing the rhythm, we have to calculate a rate. Once it is in sinus rhythm, rate is calculated easily by 300 divided by number of big boxes between R waves. So how many boxes are there? Let us count. Okay, this is one box, two box, 2.5, almost 2.5 box means, if it is 2.5 means it's all 300 divided by 2.5. 2 means 150, so 2.5 means comes around 110 to 120. Let's take it as 120 beats per minute, 110 beats per minute. And the rate is done. Axis. Now let us look at the axis. Axis is calculated by looking at the lead 1 and AVF. So in lead 1, the QRS complex is predominantly negative, that is downwards. See, if you compare this R and S wave, S is dominant, so predominantly negative or predominantly downward. And in lead AVF, the QRS complex is predominantly upward. So both are reaching each other. One is predominantly down and AVF is predominantly up. Both are reaching each other. R for R, right axis deviation. So this is abnormal. So rate is more than 100 and sinus rhythm with right axis deviation. So far it is sinus tachycardia, sinus tachy with RAD. So far our diagnosis is this. Let us look at the waves now. So first wave is P wave. Look at the P wave here, morphology of P wave. What happened here? Almost it is touching one big box. That means it is almost reaching 5 mm in height. So width is almost same, almost normal. Width is almost same, that is 2.5 mm, 2.5 mm. But the thing is, only thing is height is, it is taller. So P wave is tall. P wave is tall means more than tall P wave, more than 2.5. So that suggests P pulmonale. P pulmonale means it suggests what? Right atrial enlargement. Right atrial enlargement. So one abnormality we got. Now let's look at the QRS complexes. What happened to QRS complexes in lead 1? Look at the lead V1. What happened here? QRS complexes. There is predominant R wave compared to S. That is RS ratio is more than 1. Okay, in usually what happens in V1, the S wave is more predominant than the R wave. Usually you see RS pattern in V1, but here there is RS pattern, capital R. That means dominant R wave in V1. Look at the right atrial enlargement is again evidenced by this enlargement of initial positive aspect of biphasic P wave in V1. Normally we get biphasic P wave. Biphasic P wave. Biphasic P wave. Biphasic means both components, positive and negative component in V1. So what happens in right atrial enlargement? This positive component is elevated or enlarged. So this positive component is elevated. Say look at this P wave. This is P wave. Positive component is elevated, so increased. That means there is, this is also V1, lead V1 also says there is right atrial enlargement. So and here QRS complexes are RS ratio is more than 1, so dominant R wave in V1, that suggests right ventricular hypertrophy. Sorry, dominant R wave in V1, that means it's almost R wave is more than 7 mm to call it as right ventricular hypertrophy. The voltage criteria for right ventricular hypertrophy is in lead V1, if R wave is more than 7 mm, we can call it as, this is voltage criteria for RVH. Other things, non-voltage criteria for RVH is right axis deviation, P pulmonal. Okay, see why I am telling, because there are so many causes for dominant R wave in V1. So what are those causes for dominant R wave in V1? There are so many causes. One thing is Wolff-Parkinson-White syndrome, that is where WPW syndrome can cause dominant R wave in V1, and hypertrophic cardiomyopathy can cause dominant R wave in V1. Septal hypertrophy, that is hypertrophic cardiomyopathy with septal hypertrophy. Then some muscular dystrophies like Duchenne muscular dystrophy, and dextrocardia. Dextrocardia can cause dominant R wave in V1. Again in dextrocardia, there will be poor R wave progression, that you have to remember. And lead switch also can cause dominant R wave in V1. And posterior wall MI is very important. Posterior wall MI also can cause dominant R wave in V1. And obviously right ventricular hypertrophy can cause dominant R wave in V1. So among all these, how can I say this ECG showing dominant R wave in V1 is because of RVH? For that we have to look for associated features. So what are the other features that are suggestive of RVH in this ECG? One is right axis deviation is there, so we can call it as RVH. Another is there is P pulmonale. Right atria is also enlarged, so there is a lot of possibility that right ventricular is also hypertrophied or enlarged. And obviously the R wave height is more than 7 mm. So these are all features suggestive of RVH, right ventricular hypertrophy. Okay, so these ECG findings, what are the ECG findings? Sinus tachycardia, and right atrial right axis deviation, P pulmonale, RVH. These are all suggestive of increased pressure in pulmonary artery. Pulmonary circulation pressure is increased, so these findings are evidence that there is increased pressure in pulmonary circulation. So these leads to diagnosis of pulmonary artery hypertension, PAH. So clinical history is also suggestive of PAH, examination findings are also suggestive of PAH, and ECG is also suggestive of PAH. So the diagnosis here is PAH. So answer to question number 1 is PAH. So what are the ECG findings? Answer to the question number 2 is I already mentioned them. Again, I will repeat once again here. Sinus tachycardia, P pulmonale, RAD, and RVH. So RVH, P pulmonale, and sinus tachy. So these are all the findings that are supporting our diagnosis, that is pulmonary artery hypertension. Hope you got something out of this video. If so, please like, share, and subscribe. And if you are so interested, or if you so got some information, please feel free to leave a comment below in the comment section. Thank you.